So I just want to briefly introduce each of our panelists who have joined us. I first would like to welcome Congresswoman Kim Schreier. Dr. Schreier, hi, hello. She represents Washington's 8th Congressional District, including parts of King, Pierce, Kittitas, Chelan, and Douglas counties. Prior to her election in Congress, Dr. Schreier worked as a pediatrician in Western Washington. So welcome, Dr. Schreier. Thank you so much for joining us this morning.
Thank you. Wonderful to see you.
Thank you. And I'm also joined by Joelle Fathi. Joelle is an adult primary and acute care nurse practitioner. She has over 20 years of patient care experience at the local, national level, advocating in telehealth and tobacco control. Also served as the program director of telehealth clinics and a member of the Washington State Telehealth Collaborative. So I want to welcome Joelle with us today as well.
Good morning. Thanks for the invite.
So great to see you. And of course, any of our other speakers that were on today, I'd welcome you to join us and chime in if you have something you'd like to offer up for our discussion of telemedicine. It'd be great to have you guys as well. So I wanted to start by asking the panelists to share a little bit about your background specifically with telemedicine. I was hoping to start with Congresswoman Schreier, if we can. I'd just love for you to tell us a little bit more about yourself, your personal experience as a pediatrician and how that influenced you to advocate for telehealth in Washington and on the national level.
Well, thank you, Katie. And it's great to be here. You know, I was a pediatrician for 20 years and never used telemedicine myself. I think just because of the dates and the circumstances didn't arise. But, you know, when the pandemic hit, I think it just became plainly obvious to all of us that people needed to access care, but the very people who needed the most care were also the most fragile and the most susceptible to devastating consequences of COVID. And so it became just really urgent to rapidly expand telehealth from, you know, the way we used to think of it, which was a specialist who could join a primary care doc in the office virtually, to something where people could access this from their own homes. And so it really just came from, you know, I guess kind of just a common sense understanding, maybe a little bit better because I'm a doc myself, but it became very clear how necessary this was.
Yeah, absolutely. I think we have felt that as well here in North Central Washington. We have done some telemedicine of sorts over the last 5 years with our outreach clinic in OMAC. And we've really felt the struggles of connecting with those patients in clinic face to face. And that was really highlighted when we were kind of pushed into the more virtual care space over the last year. I was going to invite Dr. Nayak to talk a little bit more about, you know, our experience with telemedicine in Wenatchee, North Central Washington, and his background with starting kind of telemedicine for our clinic as well.
Yeah, no, I think that, you know, Dr. Schreier kind of hit the nail on the head that the pandemic kind of brought everything to the fore, but in places where there's less access, especially, you know, in these rural areas, we start to kind of run into problems related to just getting our patients in, especially in the specialty setting. You know, if they're 2 hours away coming to Wenatchee for a 15-minute visit to discuss their cholesterol, or if they're really sick, you know, having to get an EKG quickly can sometimes be challenging. But if they could go to their local clinic and then patch into us in Wenatchee, we could probably save them a lot of time, a lot of money with gas, and obviously, if it's more acute, we can get an answer to them much quicker. And so, you know, in 2015, we started to play around with that. And, you know, I see Joel on here as well, you know, as far as just getting better access to care in our remote outreach clinics. And it really was, it's a little clunky. They have to come to our clinic in OMAC. They have to get checked in like a regular visit. And then, you know, we kind of see them. It's better than driving 2 hours. But I think the game changer has been, like Dr. Schreier said, seeing the patients at home where they are. And I've been kind of humbled at how much I learned just seeing them in their, you know, regular setting. Half the time, the spouse is on the phone or on the couch with them and can give you some body language that helps you kind of gauge what's going on. And then, and I think, I'm sure we'll talk about this a little bit. There's a lot of patients where it's, you're just kind of forced to do the audio only visits because they just don't have the resources. And so either you're telling them to drive to Walmart or to drive to the clinic parking lot and patch into the Wi-Fi, or they don't even have that capability. They don't have a computer or a smartphone, and you're really kind of just forced to call them. And so I think it's brought out a lot of the different issues related to the social determinants of health that we spoke about earlier in the meeting. So our experience has been very vast and varied, and the pandemic has just kind of brought to the forefront that we need to get better at how we use telemedicine.
Joelle, I wanted to just open it up to you as well, just to tell us a little bit about your background with telemedicine. I think when we last talked to you, had mentioned some background in using it for post-surgical patients and also for tobacco cessation.
Yeah, thanks. I think, so telemedicine is something that's really been in the forefront of my mind for well over a decade. But it really kind of stems back to where I come from. I was born and raised in Montana. I had a very seriously ill mother who had to travel either west or east a considerable distance to get the healthcare that she needed in the, really the 1970s and 80s and well into the 90s. And so it really kind of sears deep for me in terms of understanding what that meant for us as a family with no money and health issues in a family. Almost 20 years ago, I ran the outreach clinics for solid organ transplant clinic in Montana, Alaska, and Idaho. And every 6 weeks, the surgical team and myself, social workers, surgeon, nephrologist, and myself would go out to these outreach clinics. We would see people who would come from miles around to see us in Alaska, for example. They would drive long distances just to see us there. Hardship, again, very poor, people from poor communities who have absolutely suffered from the social determinants of health. And even that was a hardship when we went to their state. But it was expensive, right? We were putting medical and surgical teams on airplanes around the year in dangerous weather to run outreach clinics. And but then we would transplant them and send them back to these communities, which is important for them as soon as possible. But I'm licensed in all these states because I was managing these people. And at the time, we didn't have audio video. I was managing people probably, by definition, illegally over the phone, because there's a lot to manage to keep these people safe and make sure that they don't reject their organs and or understand when they need to expeditiously get back to our facility to get them the care they need if things go wrong. I worked in the Cancer Institute, a large health institution locally, and that's where I ran tele-lung, tele-tobacco clinics for a thoracic oncology, thoracic surgery group, and also tele-lung screening. And so really kind of across that continuum of preventive care, management of people in workup for thoracic and GI cancers, and post-surgical follow-up, which again is really important. If, thinking about lung cancer alone, 90% of the people who develop lung cancer have been former or are current smokers. These people, by definition, have suffered social determinants of health. They're chronically ill and they are impoverished. And many of them are living in our rural areas in Washington. So this was long before telehealth hit. And so, even for us, there was a struggle on the medical end of not only getting our digital equipment set up, but how do we get that connectivity out there? So I'm touching on a lot of different topics in this space. We have a huge rural population in Washington State and beyond. And we're well on our way, but we desperately need people like Dr. and Representative Schreier on this call to really kind of pave the way to get what we need and take telehealth to the next step. It's an exciting time, but we can't let off the gas pedal now.
Yeah, I agree with you that the momentum over the last year has been really important. We've seen how quickly an organization can develop a telemedicine program, which we originally thought, or maybe people thought in the past, would take a significant amount of infrastructure, and we were able to do it quite quickly. But you did touch on a few of the things that I think segue into my next question was, we've talked about the benefits to telemedicine, which are quite obvious in providing care to people who otherwise may not get it, allowing people to have care where they are, where their support systems are, and to address some of those social determinants in people that may not have time or access to transportation or other things that prevent them from traveling to clinics or specialty clinics. But over the last year and a half, we've also seen a lot of barriers to telemedicine uncovered and highlighted, just in the ability to get people connected to a connected device or in an area where they have broadband or things like that. So I kind of wanted to talk a little bit more on thoughts about what are the barriers currently to telemedicine and how we may overcome some of these as we move forward.
I always have a lot to say. I want to give anyone else on the call an opportunity to weigh in before I launch that one.
I'm happy to talk about some of the things that we can do from a policy standpoint, and I'll be concise so that Joelle can expound. But of course, one of the biggest barriers is just having access to high-speed internet, and that is why in the bipartisan infrastructure plan that we're going to pass very shortly, there is $65 billion in there for building out rural broadband, for connecting people who are in urban areas where they have access but can't afford it, but also for teaching people how to use it, because there's getting connected and then there's figuring out how to use the device and use the technology. So that's one, and another is, in the meantime, when not everybody has broadband, being able to do telemedicine audio only is a big help. But the other big help is something that they're piloting at King County libraries, also in my district. And I don't know if they're doing it locally for you, but King County Library System, in several of their libraries, they're taking one room and basically, like covering the windows, making it private, having broadband, and people can coordinate an appointment with their specialist or their physician and with the library, block out time and go to their local library and have that visit using telemedicine, because it is so much more effective to have the visual with the audio. And if I could just comment briefly on Dr. Nayak's comment about the benefits of seeing patients in their own homes, whether that's a child who's more at ease and you can see how they are functioning, kind of their social emotional development in their home. I hear about that from my pediatrician friends. For me, it's been a personal benefit as my parents are aging and I'm able to attend their appointments remotely, and how much more effective those appointments become. So anyway, there's some benefits and there are some ways of overcoming them.
That's fantastic to hear about the money and the support that's coming for broadband. And I'm so glad you touched on the importance of teaching patients how to use the broadband. We cannot just provide it to them and assume that they will hit the ground running with it. So we got to set them up for success. So that's fantastic. Joelle, I'll go ahead and let you speak as well.
Yeah, sure. So kind of building on what Representative Schreier had to say, it's fascinating that 25% of King County residents are, technically it's an urban area, and yet 25% of them don't have the access or the speed to support an audio video conferencing call. And so that's pretty sobering that, we often think of telehealth in that sort of rural space, and we know that there's a massive digital divide rurally, but we see it in the urban settings too. And both populations of people could really benefit from telehealth. And really kind of thinking more broadly about how we roll this out to people, some colleagues of mine at University of Chicago recently did some research looking at various populations across the health system. And the bottom line is there definitely is a sort of line that we can draw in terms of adults and older adults who feel who are digitally literate, and really kind of that age cutoff is 50. This is what this research definitely shows. So, and that makes sense, right? If you think about those of us on this call who are 50 and older, we've seen technology really evolve from nothing to something, and so people not only don't have the access, but they even if they have the access, they really truly feel intimidated, and they just don't know how to use the devices. So it's really great that we're starting to have the discussions around, and I know some health systems are starting to look at or employ people to, help desks that are just designed to help people get up and running and confident and competent at utilizing the technology, and easing the path in terms of patient portals, being able to create that connectivity with ease, so that there's less troubleshooting that needs to happen in order to use these devices. But I think knowing the population who needs that can help us target those people.
I had a question.
I will also,
Go ahead. Go ahead. Sorry.
I was just going to say, it's really important that we think about some of the other issues around telehealth that are very real, which is, when we start launching into the telehealth space, and this is some of the stuff that we're looking at with the, Representative Marcus Riccelli, who's really currently sponsoring the House bill, I think it's 1156, looking at advancing telehealth in various ways, including language around establishing an established provider in that telehealth visit. And so while we need to break down certain barriers to ease that healthcare, I think it's really important to remember that we want a safe and responsible platform, including providers who are engaged with the patient's electronic health record. That they, we do have to iron out whether or not those patients should have an established relationship, at least with the health system that a provider is seeing them for. So there are some challenges that we're being faced with in terms of writing policy and enacting it. And I'd be curious if Dr. and Representative Schreier have some thoughts about that from those lenses.
I'd be happy to comment. They are already studying some of the safety issues. There are all what I've seen and what we've all seen, whether it's pandemic unemployment or whatever there's always scammers, right? There's always somebody who's willing to take advantage of a system. And so if you design a robust telemedicine system, will there be an incentive for some bad actors to move all of their patients to virtual so they can squeeze in more patients per day and have pay parity, and so we also need to watch quality of care, how that changes. We need to watch whether, how many missed diagnoses there are because somebody doesn't come in and say you missed the skin cancer on the side of their neck. How many teens come in, you miss their scoliosis because they weren't there in person. And so striking that right balance between the number of in-person visits and the number of virtual visits, and whether you have an existing relationship with the doctor or with the health system. I think these are very nuanced issues that I think we're going to kind of have to work out over time. And I don't think that Congress is who should be making that decision. Certainly not based on my experiences in Congress. I think that should fall to the academies, and the associations like yours to say, here's what's a reasonable amount. We can do EKGs by telemedicine. We can check O2 sats. We can maybe look at JVD, but we maybe can't see swelling of the ankles. Whatever it is, how far can telemedicine reach safely?
Yeah, I think these are actually just piggybacking on that a little bit. I'd be curious both what Dr. Shar and Joelle think as far as just the way that telemedicine is deployed across state lines. I think that's become a bit controversial as well. I mean, on the one hand, you have rural areas or urban areas with really limited access to specialty care, and maybe there's a specialist sitting in, New York City that can help right away, versus, the fact that it's really obvious that you do want to have an established clinical rapport with whoever you're doing a telemedicine video visit with. I mean, how do you strike that balance? I mean, from a legislative perspective, I imagine that's a nightmare, but maybe there's a path forward. Maybe you guys are thinking about that. And then from a practical perspective, just navigating some of those issues seems like it's really going to be a big deal moving forward.
Well, it's great to see you again, Dr. Nayak. First of all, I didn't have a chance to say that. These are exactly the questions that we have. There's even the question of, like, let's say there's a really famous XYZ doctor in some town, in a different state. Will all patients just flock to that doctor who's got great online reviews? And so, do we continue to have networks, and are those networks geographically constrained? And, we have that now, but how much does that matter once you have telemedicine? Can we go over state lines? Could somebody from Vancouver, Washington, go to Oregon Health Sciences University? Because that's really their closest one. So these are a lot of details that we still have to work out, and CMS will be making policy here. And again, I think that, groups like you should be opining on how to do this right.
I think it goes both ways as well. Us seeing the patients day to day and realizing what our pain points are and what the patient's perceptions are. We've done something called asynchronous visits in our clinic, where we use the MyChart patient portal to send patients sort of a visit questionnaire at a different time, and they fill it out and send it back to us. And we've actually reached out to patients to ask about their perception of doing this, and in general, very positive in the ability to kind of manage some of these conditions without having to come in. But also, interestingly, for certain conditions like stable coronary disease, the feedback from that group of patients was overwhelmingly, I want to come in every year and see my cardiologist. And so, Dr. Nayak and I have learned a lot over the last year or two about, how do you layer in virtual visits with your clinic visits? Is it by time period? Is it by disease state? Is it, what factors are involved? And so I think continuing to have a communication between us and members of Congress and saying, here's what we're seeing, and helping to advocate for us. I think that's where we need to continue going.
Maybe we make the rules kind of broad, right? Because we're trusting doctors to take good care of patients. Like, maybe we just trust the doctors to say, hey, this is a person I need to lay eyeballs on, and this is a person I don't. So, how much of this does Congress really need to trust or to touch, and how much of this has to be rules?
Yeah. Well, I wanted to talk, go ahead, Dr. Nayak.
No, I think that's exactly right, because, the way if you almost approach telemedicine like a tool, it's like your stethoscope, right? Like, sometimes like you really need to use your stethoscope, even though you have an echo and an EKG and all this other stuff. Like it's almost like treating it like any other tool in our armamentarium clinically. And you don't want to have to legislate that, because then you start to get into a lot of different kind of gray areas and even medical legal areas. And I think that focusing on the clinical aspects of it, I think are huge. I think that's spot on.
And we all make those decisions every day. I mean, right? Like every day we see a patient and we say, I'd like to see you back in 2 weeks, or I'd like to see you back in 6 months. So how is this any different, right?
Yeah.
Right. Or this visit isn't cutting it. I've got to see you in person. We're going to need to convert it. Can you come in tomorrow?
Yeah.
Provider discretion, right?
I wanted to talk a little bit about, Joel, did you have a comment? I'm sorry.
Yeah, just a little bit of a comment. I think I use telemedicine, as both Dr. Nayak and Katie know, quite a bit in my lipid clinic world. And I find actually, because a lot of what I do is lifestyle coaching, and I find it very effective, to once a month, tap into someone virtually to kind of be their accountability coach from their, compliance and their nutrition and their exercise. And so, and both Katie and Dr. Nayak and I are looking at some apps and things like that will also help us. But also, it's that connection with the individual patient, spouse, family, whatnot, that I see that it allows us to improve that adherence, as Jen was talking about earlier with, compliance and medications and things like that. And so I personally, I've found it, even though, and whether it's audio or video, and Congressman Schreier, I think, that's a huge area from a reimbursement perspective, because I'll be honest, we sit in these meetings all the time getting drilled about, hey, we're getting paid for the phone, and we're getting paid this for the phone and this for the video. We got to do video. And that's, sometimes that's just the wrong answer, but it is what it is, the reality we are. However, I think that, particularly with obesity, diabetes, cardiovascular disease, et cetera, tobacco cessation, as Joelle knows so well in April, we can do a lot of this virtually, and we probably should actually, because it improves our access to the patient, our access to them, and their access to us. So I just wanted to kind of put that out there.
And so much of that can be done on the telephone. The coaching that I do as a certified tobacco treatment specialist and a nurse practitioner is often the behavioral counseling and the medication management. And it actually doesn't take an audio video. It's ideal if we're on video, but many of these people we know that 80% of people who have serious mental illness are dependent on tobacco. This represents a big portion of our population. So again, these are people who have a high no-show rate in clinics. But they will take your phone call, and we do have better outcomes when we have frequent opportunities to engage in behavioral health, motivational interviewing, and all the sort of opportunities to insert the techniques that we know that work. Plus, it feels weird to ask them come for 60, 90 miles away for a quick medication adjustment when they have to drive in crazy traffic, park at high financial rates, at least for us in the city. So it not only is pragmatic and sensible, it feels ethical.
So Joel touched on that a little bit as far as audio versus video, and some of the pressure that we feel. And I'll be the first to admit that understanding the difference in payment parity for video versus audio only is still confusing for me. And I feel like it varies based on state and based on insurance company. But maybe some of the panel can clear that up for me. I think we're feeling a little bit of pressure to prioritize video visits due to this real or perceived payment disparity. And just my question to the panel is should they be reimbursed differently, and why? We've talked a little bit about some of the benefits of audio only, and there's pros and cons to each. So I wanted to kind of touch on the issue of payment parity for audio versus video visits.
Correct me if I'm wrong, but the bill that I put through that covers the period of time that we're in the pandemic emergency has pay parity for video and audio. So right now, I don't think that's an issue. However, you can look at having different pay scales as sort of yet another way that mental health is downgraded, right? The things that you can do by phone, mental health, probably diabetes counseling, endocrinologists are one of the lowest paid specialties. I think it sort of reinforces that just the bias in payment models. And certainly until we have high-speed internet everywhere and everybody has access to the same technology, my opinion is that they should be reimbursed in the same way. Another little tricky area is that, for better or for worse, I remember spending about an hour every day after work returning phone calls, and that was free. That was just my time, follow up, whatever it was. I don't know if it ends up that each one of those 5-minute phone calls then becomes a billed visit. I don't know if that's right or wrong or what that does to our medical expenses overall. But they also can be a way of keeping people from having to schlep into the office.
Yeah, I think.
I'd like to give an example. A couple of years ago, I was working with these surgeons locally, and we had two men, 90-year-old twins that live out in Port Angeles. And one of them was having some obstructive symptoms, GI symptoms. He came in, had a workup with us, and it turned out that by histology, he had a stage 4 gastric cancer. And I had just launched the clinics, and we didn't have the same payment or the legislation to support our surgeon to see that patient back by telehealth. But these were these two men, these 90-year-old twins, only had each other in the world, and one was its ears, and the other guy was the eyes. They both had deficits, and they're driving on a 2-lane highway to get to us, and they're asked to come back in to have a conversation around stage 4 cancer that could have very easily been done over the phone. And I will say this, based on our current reimbursement models, the complexity of care and the time spent with the patient would have been exactly the same in that conversation, and he did not need to be in person. And yet we had to ask those people to get back in a car and endure the strain in January to drive all the way back into the city for a conversation that is painful. And so I use that as an example of, where telemedicine can be really helpful. And if we're going to continue these payment models based on complexity of care and time spent with patients, there is so much that we can do by audio, video, and by telephone to serve our patients well.
Yeah, it's kind of interesting how even at the beginning of the pandemic, we were kind of being told to do video visits, and I had a lot of patients where I was doing that, and then now here we are again, another kind of push towards virtual visits, and those same patients prefer to just use the phone. And so it's almost like you've got a case control trial going on right now with a lot of these people. And I think it's just kind of speaking to the fact that sometimes you got to see the patient and they want to see you. And sometimes a phone call is totally fine. And I think the payment parity issue, as Katie touched on, is really being pushed towards, kind of not necessarily doing it that way. It's patient, there's a lot of uncertainty. The codes are a bit different, and then people don't know, should we build this? Should we build that? And so thankfully we live in a state where they've been very proactive. I think Governor Inslee signed into law some degree of payment parity here locally as well with state regulated insurers earlier this year. And obviously, at the congressional level with CMS and other federally financed healthcare programs, with Congresswoman Schreier, we've been able to get some degree of payment parity. And I think that that's going to need to be sorted out as we start to get beyond COVID and start to think about everything we're learning right now with telemedicine and kind of making sure we're leveraging that going forward. Joelle's great example. I mean, that's a perfect example of why we need to ensure we're kind of codifying all of these learnings over the course of the next, 6 to 12 months, maybe less ideally, but hopefully we can start to get our hands around that a little bit.
And one of our issues is that there's too much inconsistency across federal and state laws and what, for example, payment parity applies to private payers, Medicaid at the state level, et cetera. Coming from the top down, it sure would be helpful to just have a unified language that applies to all, so that we can all just kind of get on the same page and get compliant. And like you alluded to, Representative Schreier, you know, let the local licensing regulatory boards determine based on their discipline that they oversee, how they're going to manage quality outcomes measures with their providers, et cetera. And so that we can just start ironing this out and making a path forward.
There's a comment here from the audience, and I think this is something that Dr. Nayak and Joel and I have noticed in our clinic specifically, and I think it's a commonality among probably everybody over the last year or two, that initially, probably April of 2020, patients were very excited about telemedicine because COVID was what we thought was the peak pandemic. They didn't want to come in, and they were very excited about the opportunity to talk with us virtually. And then we kind of saw the pendulum swing in the other direction, and we had kind of an influx of patients who really did not want to do virtual visits, and they wanted to come back and see us. And part of that, I think, was you know, social isolation. A lot of our elderly patients had been essentially on lockdown in their facilities and not interacting with people, and they really valued that ability to come into clinic and see us face to face. And so I think, you know, we're swinging back a little bit in the other direction, but you know, how do we incorporate this now in our long-term strategy? You know, how do we incentivize telemedicine for our organizations? Because it does require a greater vision to incorporate that into how we deliver care, and how do we incentivize it for patients? Because there are a group of patients now who maybe are less enthused about it than they were 2 years ago.
I don't know if I'm the best person to answer this because I'm not practicing telemedicine right now, but I do know that with my doctor and with my parents' doctors, there are certain days when they're in the office and there's certain days when they're just functioning virtually. And so scheduling alone may shape what the practice looks like. If you know you can't see your doctor in person for 3 weeks, but you can have a virtual visit tomorrow, that will shape what people do.
I think that, you know, kind of thinking upstream in terms of how we, what our managed care models look like, what our care delivery models look like are also really important. So, you know, it's interesting because we have this value-based purchasing model where we've got payers who have patients who are in their managed care organizations. We are, as healthcare providers, under sort of these health systems responsible for meaningful care delivery that demonstrates high quality care for less money, right? So that really should be team-based. That should be multidisciplinary. And we understand that at a local level, but we're not rewarded for that. And we don't have policies in place that facilitate that. And we have, you know, a very, again, disparate payment models and varying incentives for creating, you know, developing a well population versus a sick population that continues to incentivize hospitals to have people coming back in the door. And I think most people know kind of where I'm going with this, so I'll just stop right there. We need to build care delivery models that are right for our patients, that do the right thing first and foremost, and build policy that it really aligns with our goals at a really high level, all the way down to the patient, so that we have the resources that we need to do the right thing for our patients, and we're rewarded based on that. And, you know, we don't have time to go into the nuts and bolts of that, but some of it does have to do with how insurers are paying. I also think that insurers can do more, including getting devices to their patients. I think it can't all be on health systems. I think that we need models of care that include all stakeholders, and that includes insurers, payers.
It's interesting. I think you're exactly right. And it's also interesting how, some patients really, if they're having an issue in cardiology, it could change. Like I could say I need to see them in 6 months, but, and I can see them virtually because they're so straightforward, but on day 5 month 29, they have chest pain and I need to see them in person and I can't do a video visit with them. And so the scheduling part of it, I think is actually, I've kind of tried to make this point with our EMR scheduling folks is like, if you can figure out how I can, modify my visits to virtual if they're stable and they don't need to come in versus if they're not if they're having an issue and I need to see them and the patient can control that, that would be a total game changer, especially if you can control it literally at the point of care, and I think that all of these issues, if you just put the patient in the center and you just try to figure out what's best for them at the time they need the care, you'll solve so much of these issues. Because I think as most of the providers will do the right thing for the patient, they're not so much worried about some of the billing issues and the technology, which is going to change. We're going to be doing things in a couple of years anyway. So I think these are all amazing points that everybody's bringing up. I've learned a lot.
And I will say there is some beautiful technology out there, and I try hard to stay away from brand names, but I will tell you that I have interacted with a company that has this kit that is great for heart failure patients. So Dr. Nyack and Dr. Bates discharged a patient from the hospital with a new onset heart failure. You can have a relationship with this company. They'll dispatch this kit that has an O2 sat monitor, a scale, a tablet, a blood pressure cuff, and it's everything that they need set up, right? So we need payment models. We need payers that are willing to reimburse for that equipment. It shouldn't be on the provider. It shouldn't be on the patient. The patient can set that up, and there can be personalized videos by Dr. Nyack and Bates that are triggered if the patient's weight is up by a kilo. And it can be, what was your sodium intake like? You can even dial the provider's office at any time by pushing a button on the tablet. Like, these things help, but we need payment models that support reimbursement for asynchronous monitoring, remote monitoring, and data, download and review of that data, right? Someone needs to look at it and someone needs to be monitoring it. So it's like, the innovation is there, but we have to connect all the dots and figure out what that looks like. But again, it has to be that collaborative model and that shared expense and that accompanies that shared interest in doing the right thing and figuring out how to really kind of leverage this equipment and also get that data to communicate with our EHRs. Like it's so exciting, and yet we're struggling to get all of these things in alignment. But there are ways that we can do it. I'm sure of it.
Yeah, I think you hit the nail on the head. That I think a theme that has come up in our discussion a few times is the technical support for telemedicine. We talk about in our own practice with our asynchronous visits and in telemedicine, we talk about the issue of having dedicated IT support and somebody available at a moment's notice to help us work through the challenges of our video visit that doesn't connect, and who monitors all of these remote patient monitoring data, and how do we integrate whether a patient is even appropriate for telemedicine into the EMR? How do we designate this is a good telemedicine patient so the next person down the line can say, yes, I can schedule a visit with this person via phone because they're appropriate, they're not hard of hearing or other things like that. So that's something I think we're going to continue to face challenges with, but also there's a lot of exciting things happening as far as some of the things you mentioned with the devices and these kits and some of these companies that are coming out with these resources. It's about 12:14, so I just wanted to be mindful of everyone's time and just open it up to any other final comments. It's really been a great discussion. I think we could probably talk for another hour or two or more about telemedicine and just care delivery in general. So first off, I want to thank everyone, Congresswoman Shire, for taking your Saturday to chat with us, and Joelle and the rest of the panel. But if there's any other final thoughts from anybody, I'd like to open the floor.
I just want to chime in a couple of maybe thoughts, because my practice is split between Harborview Medical Center and UW. And so uptake of these telehealth resources is very disparate depending on which site I'm at on which day. So at Harborview, it's nearly impossible, not completely impossible. I do have a few patients that can, that have the resources to be able to complete telehealth visits, but it's like extraordinarily different from my UW patient panel. So I think, you know, a lot of these technologies are will be helpful, but there are just some basic issues like unstable housing and with that theft of personal property that happens much higher in some of these patient populations than some of the other ones. So I found this very interesting. I think some of the challenges are also disparate according to people's resources as well.
That's a great point. We think about rural barriers and the fact that we are taking care of patients that are 200 miles away from us, and here you have patients that live in the same city, albeit a very big city, with these differences, and it's kind of fascinating to hear about. I actually never even thought about the issue with theft of personal property. So that's really interesting that you bring that up.
Yeah, we have I'm just to plug some of the Harborview providers. Many of the clinics have in-house pharmacists and nursing teams that hold on to meds for patients, and then have patients come in weekly or bi-weekly or bi-monthly to come in and get their Medisets filled, so that they're never missing too many of their meds in case things get stolen or lost. Wow,
that's great. Any other final comments from anyone else before we wrap up today?
You know, I'd just like to thank you, Katie, for putting this together. Just an amazing job. This whole meeting has been terrific, and really appreciate all the work you did to put this together. Liana, I see your little avatar there. Thank you for all of the great work that you've done as well in getting this meeting together. And thanks again to all the panelists and everybody that spoke. And I will say that I think we need to notify National ACC, because we got a member of Congress to actually say JVD in a discussion. I don't think I've ever heard that. And I watch a lot of the news. So I feel like I'm very proud of our representative from Chelan County here, who has done us all very, very proud in all the work that she's doing. Thank you, Congresswoman Schreier, for everything you're doing for the medical community and the rural communities here in North Central Washington specifically.
Well, thank you, and thank you for having me. I'll see what other acronyms I can pull out next time we meet. and I should note, we were just at Snoqualmie Valley Hospital, and we saw a robot telemedicine arrangement where the doctor locally could put a stethoscope on a patient and it transmitted the sound to the doctor. I mean, they couldn't do it from home, at least not yet, but maybe those stethoscopes can be rented out. I mean, you never know. You know, we developed telemedicine and technology will follow. So exciting times. Thank you all.
Thank you.
Thank you.
Well, that concludes our symposium for today. Again, thank you to all the speakers and panelists and all of our guests in attendance. I hope you guys learned something new today. There will be some email notifications coming out in the next week or so about continuing education credits, and this event will be available for playback on the ACC website at a later date as well. So if you have any other questions, please don't hesitate to reach out via email. And I hope to meet some of you in person someday soon. So have a wonderful rest of your weekend. Bye-bye.